We're going to be starting in 1 minute. Okay, we're going to get started. Welcome to Giant Cell Tumor 101, the biology of GCT. During this seminar, all participants will be in a listen-only mode. There will be a question and answer session at the end of the presentation using questions submitted through the Q&A and chat features. If a lot of questions come in, then we will go a few minutes past the hour to answer them. Please remember the information provided in this web seminar is not intended as a substitute for your physician's guidance and care. My name is Sarah Rothschild. I'm the VP of Program Services at the LifeRaft Group, and I am your moderator for today. For those who don't know, the LifeRaft Group is a patient advocacy organization that supports patients with gastrointestinal stromal tumor, or GIST, which is a type of sarcoma. And many of the physicians that treat GIST patients also see giant cell patients. So recently, we are very excited to expand our support to the giant cell tumor community, and we have lots in store for 2021. I would like to thank Daiichi Sankyo and Deciphera for their support for this webinar. Now let me introduce you to our presenter today, Sydney Stern. Many of you know her as an active member of the Giant Cell Tumor Pbns Facebook groups. If you know Sydney well, she is a wealth of knowledge and has a big heart, as her true passion is being a patient advocate for the giant cell community. She's here today to kick off a 101 presentation for the community, and we encourage you to ask questions in the Q&A and chat features, and if we cannot get to all of them, Sydney will reach out to you later as a follow-up. So without further ado, Sydney, take it away.
Hi, thank you so much, Sarah. So I'm going to talk to you guys about giant cell tumors and the biology. So a little bit about me. I'm an MS PhD candidate, which I'm going to have my clinical research MS and my PhDs in pharmaceutical science. My research revolves around oncology and drug discovery at University of Maryland, Baltimore. I specifically work with chemotherapy and improving options by developing other compounds that can be given in combination with chemo to decrease side effects and improve the efficacy. But more importantly, I'm a patient. I was diagnosed at 17 years old, and it's become a big part of my life and my identity, both as a person and as a researcher. And that happens for many, many patients like me. So I hope what you take away from this, from the patient side, is educational tools you can use to educate your doctor, as well as make informed decisions. For the pharmaceutical companies that are involved, that you see how important this is to the patients and their families, that this has a lot of impact on everyday life for them. And then for doctors to really listen to your patients and really become advocates yourself for the disease, because you'll see that there's a lot of question marks. So I will not be able to monitor the chat feature, but feel free to put anything in there and Sarah will monitor it. So we're going to cover a lot of topics. So we're going to start with what causes giant cell tumors, or GCT. What causes giant cell tumor of the bone versus tenosynovial giant cell tumor, which is also synonymous with Pvns, and we'll talk about why. We'll go through where do these giant cell tumors come from and their cell type. We'll talk about surgical interventions. It's worth noting that in this presentation, we will not be talking about radiotherapy, but it is an important part of the treatment platforms, and you'll get a survey at the end of this. And if you want to hear more about radiotherapy as an option and what the literature says, put that in as a suggestion and we can have more webinars like this. We'll also go through what are the two main proteins that are part of the molecular biology of these tumor cells. So we'll have a little crash course in molecular biology. And then we'll go through the drugs like tyrosine kinase inhibitors that work with, like Turalo, that work in tenosynovial giant cell tumor. We'll also go through rankle drugs that work in giant cell tumor of the bone. And then we'll talk about the new generation of giant cell tumor drugs and what's next. So what is giant cell tumor? Giant cell tumor is known as a benign neoplasm of unknown origin in the bone or tenosynovial or tenon sheath. The World Health Organization classifies it as an intermediate tumor that is locally aggressive. Commonly, giant cell tumors are treated by similar people in sarcoma centers, so it's very important we distinguish the differences of giant cell tumor and cancer. So giant cell tumor is not always going to be fast growing. It can be locally aggressive. It rarely metastasizes, and we'll talk about what that actually means. And it puts stress on the bone, tissues, and joints surrounding. Whereas cancer is systemically aggressive, it often metastasizes to other organs or areas of the body. It can be life-threatening, and it dissolves and invades healthy tissue. What these share in common and why they're treated in very similar ways is they're both fast-growing in some patients. The tumors have no distinct boundaries, making it very difficult to remove. They can affect healthy tissue and bone, and then they're treated with similar drugs like chemotherapy. So what causes giant cell tumors? Most giant cell tumors occur sporadically, which means they're neither inherited nor passed down through your family. So these happen randomly. You are not more likely to get it because you know someone with it. So the prevalence of tenosynovial giant cell tumor, which again, we'll talk about why that's synonymous with Pbns and giant cell tumor of the tenon sheath. But the prevalence of this disease is the same among men and women, and the onset occurs usually between 30 and 40 years old. The prevalence of giant cell tumor of the bone has slightly higher predominance in women, and the onset is shifted more towards the 20s and 40s. It's important to note that giant cell tumor strikes randomly and is multifaceted, which means no environmental, geographical, occupational, dietary, lifestyle causes giant cell tumor that are known. So there are no specific risk factors. And if there were major risk factors or one single reason all of our rare patients have this, we would know, we would notice. So it's likely multifaceted. So where do these cells come from? There are hundreds of different cells in our body. There's cardiomyocytes, which are elongated and have single centers, and that works to contract your heart. You have hepatocytes, which are liver cells that are compact very closely together with multi-nucleus or multi-centers. You can have white blood cells, and we'll talk a lot about white blood cells. And those white blood cells can be monophages or macrophages and monocytes. There's many different types, as well as adipocytes, which is fat tissue. So the cells that make up these tumors are just as different as the cells throughout your body, like your cardiomyocytes or heart cells and liver cells. So tumors can begin in almost any type of cell in the body. The type of cell defines the biology of the tumor, and the location influences your treatment plan. So the surgeon generally can remove the tumors, and that'll be analyzed by a pathologist, which will identify the cell type usually through biopsies or after surgery when they collect specimens. The medical oncologist and orthopedic oncologist use this information to plan a course of action. So generally, multiple people, multiple doctors and physicians are involved in your treatment plan. As we said, the type of cell defines the biology and the tumor classification, and the location will influence the treatment. So it's important to note that giant cell tumor is an umbrella term. It is a biology and a tumor classification based off the cells. The location or the disease types that you can have is giant cell tumor of the bone, or giant cell tumor of the tenon sheath, tenosynovial, or Pvns. Those are all going to be, again, we'll talk about why they're the same disease, but giant cell tumor is an umbrella term for these diseases. So it's either the cell type and the location that will define your disease. So giant cell tumor of the bone and tenosynovial giant cell tumor are both giant cell tumors, but they are very different diseases. In the same way that non-Hodgkin's lymphoma and mesothelioma are both lung cancers, but they are completely different diseases and treated as such. So what's similar about these diseases? Why do we lump them into the same family? They both have blood and immune cells with single rounded centers or multiple centers. This suggests that they grow from the same place, despite whether they form on your bone or whether they form in the joint. So giant cell tumor of the bone is a connective tissue tumor that arises near the joint at the end of a bone. whereas giant cell tumor of the tendon sheath, tenosynovial giant cell tumor, are connective tissue and epithelioid tumors that arise in the tendon sheath or synovium. So tumors and tumor lesions can come in many different forms. It's not just the giant cell family. So commonly people who are misdiagnosed previously, so giant cell tumor is a differential diagnosis, which means you have to remove the possibility of these other diseases before you can get this diagnosis. So commonly people get diagnosed with osteosarcoma because it occurs in the similar location towards the end of a bone. But after pathology reports and resection, you can get the diagnosis of a giant cell tumor, which happens towards the end of the bone, towards the growth plate, which is this area right here. Or you can have tenosynovial giant cell tumor, which occurs in the tendon sheath, the synovium, and in the joint. So what make up these tumors? So we have fibroblasts. These are cells that make up connective tissue and they'll produce collagen. Monophage and macrophage, we'll talk a lot about these. These are part of the white blood cell family and they act in the immune response. So you can have white blood cells that become macrophages or become monocytes. And that'll influence your immune response, swelling, and other symptoms you may see in these diseases. And then you have osteoclasts. These are a type of bone cell that absorbs bone. So when we talk about the giant cell tumor of the bone, we'll start with the subtypes. So there are 3 subtypes. You have type 1, which is mostly tumors that are made up of fibroblasts. Again, that connective tissue tumor or connective tissue cell that makes collagen. In early stages, like in this type 1 tumor, the cells rely on cell multiplication for growth. Whereas in type 2, you have a combination of fibroblasts and macrophage monophage, or that white blood cells, and that leads to the recruitment of other cells from the bloodstream to come swarm the tumor and enlarge. And then lastly, you have type 3, which is the most destructive. Most patients, when they find out they have the disease, it's more when it causes damage, or type 3. And so this is when the tumor cells become osteoclast-like, or that bone cell, and it'll start to reabsorb or dissolve host bone. So in 2013, the World Health Organization classified Pvns, or pigmented villanodule synovitis, as a giant cell tumor. So these diseases, Pvns, tenosynovial giant cell tumor, or Tgct, and then giant cell tumor of the tendon sheath became one disease. So commonly you hear them referred as singular diseases, or that one is a localized form and one, they're all the same disease now. And so these also have subtypes. You can have the diffuse type, the localized, intra-articular, and extra-articular. So I'm going to refer from here on out to all 3 of these diseases as just tenosynovial giant cell tumor, or Tgct. So Tgct can either be localized and intra-articular, or it can be diffuse and extra-articular. And we'll see what that means. So intra-articular would mean that it's between the joint in the capsule, whereas extra-articular, E for extending out. So it's going to extend past the joint capsule and go into the upper or lower portion of the bone. And so these tumors are made up of giant cells and immune cells. These monophase and macrophages, as I said, you'll see these guys a lot. These act in the immune response and become part of the bulk of the tumor. So what's diffuse versus localized? Diffuse is tumors that occur in larger joints generally. They have no distinct boundary, making them really hard to resect. They end up larger. You have multiple nodules and more aggressive growth patterns, which leads to higher recurrence, somewhere between 50 and 70%, depending on the source. Localized occurs in smaller joints. They have very distinct boundaries, usually encapsulated, making them easier to remove. They tend to be smaller, singular tumors. They're less aggressive due to reduced growth patterns, and they have lower recurrence rates, somewhere between 15 and 30%. So it's important to note that a lot of us are patients on here, and the patient forums are predominantly diffuse. But it's important to note that roughly 90% of cases are actually localized. So it's a minority group that do have a very aggressive and chronic debilitating disease, which is the diffuse form. But those people, this should be a disease not about the majority. It needs to be about the exceptions and progressing that treatment, because it ends up much more debilitating. So giant cell tumors can arise in the same cell classification regardless of the location. So we're going to start with Tgct, which occurs again around the joints, tendon sheath, or bursae. And so you have the red arrows are for Tgct, and the thickness of the arrow refers to the predominance of that location. So you have 75% of these tumors occurring near the knee. with hip coming in second, shoulder, fingers, ankles, and toes coming in last. For giant cell tumor of the bone, you have tumors that occur at the end of the bone. 50% of them will arise around the bone, with less than 1% occurring in smaller bone locations. The distal femur, or the lowest part of the femur, is going to be the most common. The proximal tibia, which is above your shin bone and below your kneecap, is the other most common location, followed by the proximal humerus, which is your shoulder. You have your distal radius, which is part of your wrist, sacrum, which is part of your tailbone, and then your feet. So it's important to note that in 5% of cases of giant cell tumor of the bone, metastasis can occur. Metastasis means that it spreads from the primary location, usually to the lungs. X-rays are needed to monitor this, and majority of giant cell tumors do not spread both bone or tenosynovial. They rarely occur in multiple joints or organs. But it's important to note that although giant cell tumor of the bone can be localized, it can still spread to those lungs. And so the metastases of giant cell tumor are still giant cell tumors. They're calcified, but they must be monitored. They are not considered cancer or lung cancer. And I really like this depiction down here of Sting in New York. So an Englishman in New York is still an Englishman. A giant cell tumor is still a giant cell tumor, no matter where it is. So at the time of diagnosis, giant cell tumors can have caused damage or may have been found on routine scans. A localized Tgct or type 1, type 2 giant cell tumor of the bone may be cured with surgery alone, but even after surgery, giant cell tumors can recur. If the Tgct is diffuse or type 3 giant cell tumor of the bone, the risk of recurrence is much higher, and the giant cell tumor may recur following multiple surgeries, which becomes a big issue, and comorbidities start to occur. So just issues because you have so many surgeries. So in that case, systemic drug therapies may be needed. So we're going to talk about the surgical interventions, the most common ones. So for the last 30 years, the surgical interventions have not really changed much, which is either here nor there, but it's understood these may be an outdated method of removing the tumors if they recur. So for giant cell tumor of the bone, you can have a bone graft, which replaces missing bone in order to repair. You can have the bone curettage, which is the removal of the bone through scraping it with a curette. You can have segment resection, which is the removal of the bone, leaving a gap and requiring reconstruction either with cement or cadaver bone. All of these attempt to remove the tumor and the damaged bone. For Tgct, it's a little bit more up in the air. Synovectomies are the main way to remove it, but whether you use an arthroscopic or open approach is still, there's no consensus on which is better. So the arthroscopic or the keyhole synovectomy is the removal of inflamed joint lining and synovial tissue using an arthroscope, so little keyholes. You can have an open synovectomy, which is the removal of inflamed joint lining and synovial tissue through an open approach. This tends to be a more elaborate surgery with longer recovery times. In both cases, you can have joint replacements depending on the damage. You can have a total knee or a total hip replacement. If you have a giant cell tumor in the ankle, you may be opted for an ankle fusion. And in both giant cell tumor of the bone or tenosynovial giant cell tumor, amputation can result after multiple surgeries and recurrences. So it's very important to note that surgery is the current, say, standard of care for people who are diagnosed with this disease. However, the open versus arthroscopic approach is still not known, which is better. It really depends the source, so there's no consensus, making it much more difficult to get these patients the treatment that they need. Recurrence rates in that localized are lower. They're around 14, 10%, and recurrence rate in the diffuse is much higher. So when surgery is no longer an option, surgery may be the first line approach. However, when tumors are considered inoperable due to either the location or the extent of the disease, and if recurrence occurs, there tends to be no standard of care. It depends where you go, depends where you live. So following treatment options tend to be based off individual characteristics like pain, mobility impairment, functional impairment, joint and bone damage, severity of disease, and other patient characteristics like how old you are and how active you are. So other treatments besides surgery are based on how the tumor develop and grow. So we're going to talk about the two main proteins involved in each disease, and we'll go through them very systematically. So we'll start with a little molecular biology. So in Tgct, these cells express higher levels of a protein called CSF1 or colony stimulating factor 1. This protein stimulates the multiplication of pro-inflammatory cells. So when this tumor cell signals with the overexpression or producing too much of the CSF1, it recruits the immune cells over, and that makes a bulk tumor. For a giant cell tumor of the bone, it expresses higher levels of this protein called Wrinkle, and that promotes bone cell development through the activating of osteoclastic precursors, and that'll lead to the giant cell tumor bone cells to start eating away at bone. So we're talking about protein. You can't really talk about protein without covering genes. So genes are DNA, or the code, a blueprint for cells' protein. The human genome encodes more than 30,000 different kinds of protein, and different cells will make different sets of protein based off their function. So the genome is a library where different cells read different books. So for example, you have muscle cells that act on myosin and actin, and that allows you to type on the computer and start to contract your muscles. You can have red blood cells, which make hemoglobin, and that allows your body to circulate oxygen. You can have neurons that make ion channels, and those ion channels are allowing you to process the information I'm telling you right now. So each cell has their own distinct purpose. So you have DNA, which is that constructive blueprint, and then something called RNA takes that blueprint and creates it. And it creates it into what we know as protein. And protein is built up on the building blocks, which are amino acids. There are 20 of them. And variations of those 20 amino acids lead to all of the proteins in your body. So you have alanine, which is designated as a single letter, as A. You can have lysine, which is designated as K. And so this becomes like our own language. And so a protein sequence may be anywhere from 100 to thousands of amino acids long. So the proteins in this group we care about is Wrinkle. And Wrinkle is 616 amino acids long. It starts with an M, which is a methionine, and it ends in an A, which is alanine. You have the CSF1 protein, which is 552 amino acids. It also starts with a methionine and ends in a leucine. And so these different amino acids interact and make these proteins. This is what the proteins look like. They're not color-coded in our body. That would make life way easier, but it's a good way for computational biologists to understand how they interact. And so you can see there's curls, there's flat areas, and that's all based off how the amino acids interact with each other in the world around them. So in science, we use a lot of jargon, so it's important to discuss what that means. And so when we talk about CSF1, we're talking about both the ligand, or what binds to the receptor, and the receptor itself. They both are called CSF1. So you can either have drugs that block the ligand or the receptor, but they're referred to in the same way. So for the same way, like CSF1, Wrinkle is the same. You have Wrinkle, which can be the ligand, or what binds to the receptor to send a signal. Or it can be the receptor itself that takes that signal and makes a response. So CSF1 is one member of a very large family. So it's the human tyrosine kinase family. This acts as like a family tree. So you can see over here, we have CSF1. KIT right next to it is a sister human tyrosine kinase, or protein. And you can see ABL, which is way over here in red. It's a distant cousin. They may only get together for Thanksgiving. Wrinkle has the same thing. Wrinkle is a huge family of proteins. It's the tumor necrosis family. And so Wrinkle is in part family 11, as you can see. And so all the other members in family 11 are going to be sisters and siblings. Whereas if we go to family 8 over here, these are cousins. But because they're in the same family, they share similar molecular features. And so when we talk about these tumors create too much of these protein, how? So a mutation is a change in the DNA sequence encoding for a protein. Mutations can occur randomly, but cells carrying certain mutations can either die, it cannot affect the actual cell, or it can cause them to grow. The translocation is a chromosome abnormality in which a chromosome breaks and attaches to a separate chromosome. And you'll see what that means in a minute. So we'll start with giant cell tumor of the bone. It's worth noting that in over 90% of cases, there's an H3F3A mutation. So we each get chromosomes from our parents, and within each chromosome, there's hundreds of genes. And those genes are tightly packed and held for safety. But this mutation leads to a change in how tightly these genes are held. So it causes them to unravel. And we don't know what this means for the giant cell tumor of the bone, and we don't know what it means for the patients. But it's important to note that this would be a great area to continue research in. So rankle, there's overexpression, there's too much of this rankle protein, which is made by the giant cell tumor of the bone, and it stimulates bone reabsorption, which will increase the growth of the tumor and destroy the bone around it. So we have this little osteoclast-like cell eating away at the bone. And so while we don't understand what that mutation does for giant cell tumor of the bone, we do understand that CSF1 translocation and Tgct is why there's an overexpression in that CSF1 protein. So translocation, again, we can see that we have a chromosome in green and we have a chromosome in pink. And in a translocation event, they swap ends. And so this happens in the in the Tenosynovial giant cell tumors, and that leads to an overexpression in this protein by the tumor cells. And that leads to recruitment and growth of these immune and inflammatory cells, again, which become part of the tumor and recruit other cells. So how do these drugs work? So we're going to start with Tgct and Trial. So originally these drugs, these targeted drugs, were not made for giant cell tumor of the bone. They were made for, in this case, chronic myeloid leukemia, which is a rare leukemia. It's a cancer of the blood. It looks very different than Tgct, but at a molecular level, these diseases tend to be more similar than we thought. So the mutation causing chronic myeloid leukemia is in a gene called ABL, which was discovered in 1985. If you remember ABL, it's a distant cousin of CSF1. And so because they're distant cousins and they have similar functions, drugs that inhibit or shut down the ABL work surprisingly well with CSF1. So imatinib inhibits the ABL, that cousin of CSF1, and imatinib was revolutionary. People called it the magic cancer bullet. Although there is no current magic cancer bullet, it was as close as it was for the time, and it opened a door for giant cell tumors like us. So because these are all in the same family, it became a first generation or off-label drug used, imatinib and nilotinib, which were developed for chronic myeloid leukemia, but they work really well in triple negative in tenosynovial giant cell tumors. So these therapies work by blocking CSF1. So you can see imatinib or Pexydartnip. So they block the CSF1, which doesn't allow the tumor cell to talk to the other cells around it, keeping the growth small. So this is from the manufacturers of Pexydartnip, which is the current approval drug that was just approved August 2019, and we'll discuss it more. This drug blocks the receptor, therefore it cannot signal to the other cells, no recruitment, it doesn't allow the cells to communicate, and then therefore it won't allow them to grow. It's worth noting, Pexydartnip or Trial is associated with spontaneous or idiopathic hepatic toxicity in rare instances. This is very rare, but it's important to develop a plan to monitor the hepatic toxicity and other side effects with your prescribing oncologist. In this case, it's part of the FDA risk assessment strategy, which requires the prescribing oncologist to have a plan to monitor this. So we covered Tgct. We're going to move into giant cell tumor of the bone. So how does Wrinkle drugs work and how do they work? So again, these drugs weren't made for giant cell tumor. Originally, the drugs were made for osteoporosis and the prevention of bone metastasis in solid tumors. So both in osteoporosis or other solid tumors, there is bone loss and fragility fractures that can occur in both cancer patients and postmenopausal women. In 2010, Dazunimab was approved to reduce fragility fractures and bone density loss in both cancer patients and postmenopausal women. Again, surprisingly, it works very well in this disease. So the Wrinkle Inhibitors rely on monoclonal antibodies, and we'll discuss what that means, that bind a wrinkle and that prevents it from attaching to the receptor of osteoclasts, which are those cells that are going to eat away at the bone. So the Wrinkle Inhibitors reduce the survival, the function, and the bone reabsorption needed for these tumors to survive. So the Dazunimab relies on a monoclonal antibody, which means that it's an engineered protein that binds to one substance. So here's your engineered protein and it's binding to the wrinkle, so the wrinkle can't bind to the osteoclasts. Here's another great depiction of it. So you have the Dazunimab, which is the Ys, and it binds to these wrinkles so it can't bind to the receptor and it can't lead to bone reabsorption in these osteoclast cells, which ends up being the tumor cells. Despite the success of these drugs, more therapies are needed. Some giant cell tumors are unresponsive. Tolerability is variable, so whether people have side effects and can stay on these drugs. And then treatments both the Wrinkle and the CSF1 inhibitors may halt the growth, but they generally don't eliminate the growth. Most people have partial responses, and complete responses are kind of the goal for these patients. And because there's only a partial response in most cases, the duration of the treatment is variable. Sometimes these people are on the drugs for the rest of their life. And that matters when you're giving a 20-something-year-old these chemotherapeutic drugs. So proper treatment and proper dosing and duration will need to be determined. So what's next? What's on the horizon? The new generation of giant cell tumor drugs. It's worth noting that Bernthal published something in Sarcomas that says surgery remains the most common treatment in Tgct. However, there may be an increasing role for adjuvant or drug therapies, including these new targeted therapies. Weighing the side effects of these treatments and their symptomatic benefit will be based on a patient-by-patient basis. So we're getting more into patient-by-patient treatment options and more precision medicine based off your specific characteristics. For giant cell tumor of the bone, dazunimab, again, that monoclonal antibody that binds to Wrinkle, resulted in dramatic treatment response, which led to its approval to begin with. However, recent advances in the understanding of giant cell tumor of the bone growth, so pathogenesis means growth and how it develops, is essential to develop the new treatments. So for giant cell tumor, the focus is more understanding how the disease works, whereas TGCT, they're trying to find new targeted therapies. So you'll see a difference in the understanding of those. So as we talked about a little bit, we have Pexydartnip, which was approved in August 2019 for adult patients with diffuse type TGCT or pigmented villonodular synovitis, which was on the clinical trial information, who have received prior treatment and have high recurrence rates or inoperable tumors. So I put the clinical trial information. They're still doing clinical trials to see about duration treatments. So again, these patients may have to be on it for the rest of their life. You're not sure if you can take holidays, you can take breaks for a little bit. So all of that is being studied right now. And I will make sure people who reach out and want to be a part of these clinical trials have that information. There's also Facebook forums like the Trello FDA approved treatment for Pbns group, which is very active if you want to know about the side effects and how people's patients' experiences are going. We also have the CSF1 drug called DCC-3014. It's from Deciphera. This is one of the most exciting ones to me. It seems like it's going really well. And so on August 18th, 2020, they started recruiting patients with malignant solid tumors as well as TGCT. And so here's there's also the clinical trial information, and there's a Facebook forum with the DCC-3014 research trial for advanced tumors. And here's some preliminary data that they've been showing, which shows that the plasma concentration, or your circulating, so in your body, the circulating amount of CSF1 goes up with this drug, which means it's not able to bind to the tumors. It's not able to bind to the immune cells, which is good. That means it can't talk to each other. So you want more in the blood. So it's showing really great results in anti-tumor effects. And so currently they're in phase 1 dose escalating studies, which are ongoing, where to provide information on how tolerable the dose is. The initial proof of concept in patients show really great preliminary anti-tumor activity and potentially a more favorable tolerability profile, which is a big challenge for the current treatments. So stay tuned for that one. And then I wanted to mention one more is a Fpa008 trial. It's about a monoclonal antibody. There was an agreement in 2015 with Bristol Myers Squibb to develop this drug, and they did clinical trials. Although the status on the FDA website says the trial is complete, I am not personally sure where it is in its pipeline for being approved, but it is an antibody treatment that blocks CSF1, so it blocks the receptor. So we didn't forget about giant cell tumor of the bone. There is zolduronic acid, or bisphosphonate, as it's called commonly, in an academic research lab at St. Louis University. They're looking and recruiting since February for trials to determine the effectiveness of locally administered bisphosphonate on the affected region. So during surgery, they'll go in and they'll add this bisphosphonate and measure the impact of tumor recurrence used in combination with surgery. And so this bisphosphonate, what is thought to happen is that it'll strengthen the bone under it, leading for those osteoclast-like cells and those tumor cells not to be able to break through the bone. So now what? Now what do we need as patients? So we need definitive pathology. So H3F3A is a mutation that's very common in the giant cell tumor of the bone, as I showed, but what does that actually mean for the patients and their outcomes? How does the CSF1 and TGCT, that translocation, how does it begin occur to begin with? That would be nice to know, as well as other targets. So in some of these, you have insulin growth factor differences as well. And it would be nice to know if there's other targets involved in the growth and signaling of these tumors. We also need information about treatment options. Is surgery better, and what approach is actually better? We don't really know whether it's a keyhole surgery or open approach, or what type of resection would be best for certain patients. As well as, can you give drugs and surgery in combination? That's what we're seeing as a push, is a multimodal approach. However, not a lot of clinical trials have been done to determine how long should you be giving the drug before and after the surgery, as well as patient-centered research and patient-centered care, which the LifeRAF group has been great with starting to push into, is developing a patient registry, which should be in 2021, as well as continued educational seminars like this one. And it's worth noting that the Connective Tissue Oncology Society did have a meeting that included these diseases. So it's important to see these diseases in the light of both medical science and in patient advocacy. So I am definitely ready for any questions.
Amazing. Excellent presentation, Sydney. Thank you so much. Okay, so we do have some questions that came in, but we do have time if anybody else wants to chat or type in their questions in the Q&A or chat features. So to get started, the first question is, if you have a recurrence, are you in the diffused category?
Not automatically. So recurrence can happen in small populations, again, that 15% that occur in localized forms. You would be a minority in the localized form, so it is worth reviewing that pathology report, but you can have recurrence with a localized diagnosis.
Okay, thank you. Are there any studies of long-term Denu Misab for giant cell tumor of the bone? This person has a child who is young, and so long-term is a concern.
So from my knowledge, it was approved in the early 2000s. So that data would be from then on. So it depends what you mean by long-term. 20 years or 15 years is quite a long time for me. But if you want a lifetime, you would still need more time. Like imatinib has a lot more data and long-term side effects. Also, dazunimab is not meant to be taken for the rest of your life. It definitely has cycles. So when you do have patients on it for a prolonged period of time, there is that concern. As far as research in that concern, I think it's a patient by patient basis, because the risk of stopping taking the drug is higher than the risk of the side effects.
Okay, great. Is there any correlation to hormonal issues in your opinion?
So as I said at the beginning, if one, for Tgct, it's important to point out that the prevalence of female to male is the same. So if it was a sex-linked hormone, it would likely be seen, you would see a higher predominance in one or the other. So it's unlikely it's sex-based or sex-linked hormones like estrogen and testosterone and progesterone. In small cases of type 2 and type 3 giant cell tumor of the bone, insulin growth factor has been associated, both 1 and 2 have been associated with increased activity, but I probably not what they meant by hormones, maybe. So yes, in giant cell tumor of the bone, but not sex-linked hormones is the.
Okay, thank you. Any information on Pvns with age? This person is 67 and has been told that Pvns diminishes with age.
So a lot of the times medical professionals base their answers on experience, which is wonderful. That guides intuition and guides gut feelings, but the large body of data is, because it's such a rare disease, it actually, there is a prevalence of the disease in older people. So 40 to 60 tends to be the range. So I have heard very often people say that they may grow out of it, and that's generally not the case. If that is going to be the case someday, it has yet to be seen as a very obvious answer in the literature.
Thank you. This person wants to know, do you have any information on the results of the DCC trial? Any updates to share?
So they're ongoing. So there's that wonderful Facebook forum of the other DCC 3014 members who have a lot of information. Currently, it's a very small, obviously, if someone wants to be involved, that's great, but it's a small group right now, and they're still in the recruitment process. So the data has not been fully determined and evaluated because it's in a small group and they're still ramping up. It's still in between the early stages of the trial. So currently there's only early stage data, which is some of the stuff I showed.
Okay, great. What medical centers are leading in research for medical options for TGCT PBNS?
So one of the great things about the LifeRaf group is they hope to put together a specialist list, which should be coming out in 2021. And I will hopefully be a big part of helping to put that together. From a United States standpoint, Memorial Sloan Kettering Cancer Center is very renowned. Bernthal at UCLA, and you have Dana-Farber, which is the Harvard Medical Center. So you have the major institutions really being predominant. MD Anderson plays a big role, so Houston area. So major cancer centers tend to be the predominant force in progressing this disease. It's very unfortunate if you don't live near one of these major centers, but probably those major regions, UCLA, Memorial Sloan Kettering Cancer Center, and MD Anderson are probably the predominant force. For the UK system, I know it's Stanmore is pretty high up there. I think it's in London.
Okay, great. Giant cell tumor of the bone, how many of them are in the proximal femur? Do you have that sense?
So that's around the knee. So 50% of all giant cell tumor of the bone are around that knee region. So the proximal ends up around that region. I'm not sure if there's like an actual guesstimate for those values, because again, it's a rare disease. So prevalence would rely on a lot of people. So I probably around 50%.
Okay, thank you. We have a lot more questions coming in. This is exciting. If there is a large immune response in the body, like getting sick, will this potentially increase growth in TGCT since they take on the monocytes and macroimmune cells?
So these cells are signaling directly to them. So it's not necessarily a systemic immune response. So it's not like getting sick with a cold where you're fatigued, you're coughing, you have all of those bodily systems. This is a localized growth. So it's signaling to localized through the bloodstream to come to that localized area, which is commonly why you see swelling and a large amount of issues with edemas and stuff. So large amounts of swelling. And so that ends up being a big part. You couldn't necessarily like use immunosuppressors because you need your immune system. There's a unknown component of the immune system that actually fights tumor growth, which needs to be much more understood in all diseases, but you don't want to totally knock out the immune response to get rid of these tumors either. So it's because it's locally signaling, it makes it much more complicated, which is why the targeted therapies are mostly directed towards targeting the tumor's ability to signal outward.
Okay, thank you. So this person asked about the relationship with giant cell tumor to sarcoma. Can you explain that?
Yeah, so the longer you're in giant cell tumor and the longer you're in the world of sarcoma, there's much more overlap than you think. The major hallmark is it's not life-threatening. That's where it's a double-edged sword. You're almost lucky you don't have cancer, but then there's the debate that how important like you feel as a patient because you don't have a disease that people are dying from. So although it's related to sarcoma, it signals other cells. The tumors interact with the body in a similar way by signaling. They are not the same because they cannot become malignant. They cannot become cancerous, and very small chances of that actually happening. So that's the major difference, is that malignant feature. But when you look at how the cells interact with each other and signal outward, they tend to resemble, which is why they're treated with the similar targeted drugs and chemotherapy targeted. They're chemotherapies, but those tend to be more specific and more helpful than rheumatoid arthritis drugs and things as steroids, because it signals in a very similar way.
Okay. So you said for giant cell tumor, there's a mutation that was causing the DNA to be looser. Is there any hypothesis of what this might cause in the case of this disease?
So it's hard. In order to publish something in science, you have to have more than just a hypothesis on why. You have to have proof, tangible evidence that you publish that supports your mechanism. And as it relates to giant cell tumor of the bone, it is not known what that mechanism is and whether if that actually affects the tumors and whether it affects their growth, specifically whether it makes the genes in that area more accessible is unknown to how that affects the actual tumors. So as far as a hypothesis, I would be hesitant to think of anything without actual data to support it.
Speaking from a true scientist. All right. I have had surgeons say that a TKR will likely remove the problem of TGCT permanently, but people in the group have had exceptions to that. What is the probability of recurrence after TKR? Maybe you want to also explain what TKR is.
Yes, so total knee replacements, they are very common. The tumors do so much damage, they eat away at the area. Most patients result in either early replacements or they end up with amputations. So it ends up being a really big issue for the patients. But yes, there is a group of doctors who do believe if you replace the joint and the bone surrounding it, the tumors will have nothing to grow on. The tumors grow from synovial tissue and fluid. If you can't get rid of that is my nice answer. You just can't get rid of the fluid around your joint. Otherwise you wouldn't be able to move it. So the likelihood of it recurring after a replacement is much lower. That said, it can still recur, which is why you see people with diffuse TGCT in the groups having recurrence even after replacement. So a lot of the major institutions find replacements useful when the native bone or your host bone, the one you're born with, starts to decay and become destroyed by the tumors. Then you can have the replacement. But to replace the bone and the joint solely to get rid of the tumors is not a foolproof plan.
Okay, thank you. If you haven't had a recurrence, how often should a patient be following up? I think that's helpful because the doctor doesn't seem to feel like it's a big deal to follow up. So what are your thoughts on that?
Yeah, it really depends the type you have, whether you've had recurrence before and who you're seeing. So a lot of the times I say that this is a patient-driven disease. Patients dictate their own care. So if you have had recurrences or you have the diffuse type, annual MRIs tend to be very helpful, even biannual, so every 6 months. If you have localized and it was 5 years ago you had it resected, there may not be a need to keep doing MRIs and considering it. For giant cell tumor of the bone, it's a little different because once you have one recurrence of giant cell tumor of the bone, you are much more likely to have a recurrence again, and you're more likely to have it metastasize to the lungs. So it depends with giant cell tumor of the bone, your location. So the people who have it in the sacrum are way more likely to have recurrence, and they're way more likely to have recurrence and metastasis in the lungs. So it depends your case, your characteristics. As a blanket statement, I would say if you've had recurrence within the last 5 years, probably annually is appropriate or biannually. But it depends your doctor and it depends your specific patient characteristics, how active you are, whether you've had recurrence, whether you're localized, all of those.
Okay, great. So this person says, I see treatments with chemotherapy, surgery, or oral medications. However, when I did my research, I read that radiological synovectomy treatment is also a successful procedure to remove the remaining tumor fragments after surgery or to prevent recurrence. That is placing radioactive medical isotopes such as Y90, Re186, or F32 into the joint. If you are informed about this, can you tell us about this treatment and its effects?
Yeah, so that's why radiotherapy can be a talk in its own. Radiation as a whole, so not including localized radiation, which is those Y90 or radioactive isotopes that you're actually putting between the joint. I'm assuming this person is a Pbns or Tgct person. That radiation in giant cell tumor of the bone and radiation in Tgct are generally avoided and should be avoided, as malignant transformation can occur. You can have sarcoma induced malignancies occur. So these tumor cells become malignant because of the radiation. It's around 1%. So it doesn't sound like a lot until it's you. So because of the risk, that has led to the lack of use, as well as radiation alone has not shown impressive consensus. So majority of the literature kind of says yes, kind of says no, there's no concrete answer. And when there's no consensus in the literature, because of the risk being so high, it is generally not used. In the large cancer institutions like Memorial Sloan Kettering, UCLA, they try to steer away from the use of radiation in these patients. As far as localized radiation, it just needs more time. There's not enough randomized trials to say that the patients with these Y90 isotopes would do better with surgery alone, or if that was the major determining factor. So it's just new. Again, this is where standardization and where interests start to come in and start to play a role in our patient care, is that the more interest, the more research that's done, the more answers we get. And we're just a little behind on that. So the same with cryotherapy and all of those other techniques that are being explored now. They're just more exploratory than they are clinically used and clinically relevant for an 100% option right now.
Lots of questions, guys. I don't know if I'm going to be able to get to everything, but I'm going to send them to Sydney to answer. Just a comment, as somebody was interested in hearing an update about the Decipher trial. There was a recent publication that came out at that CTOS meeting. It's in the public domain, and of course we can make that available. You had mentioned age as a factor in metastases to the lungs, but with giant cell tumor of the bone, are the lung mets more likely if your tumor is spinal?
Yes, so lung met is most common. So met, common term for metastasis, is more common. It's around 5% of giant cell tumor of the bone do metastasize to the lung. So it's a small proportion, but the vast majority of those patients have had recurrence or have spinal giant cell tumor of the bone. So it's a huge concern in those patients, and regular x-rays to look for calcification in the lungs are generally used.
Okay, great. This is also a global forum, so we have people outside the United States who are attending now. The question is, are the treatments you mentioned mainly in the US, are there any other oncology-based treatments that are available in other parts of the world? This person specifically is interested in the UK.
Yeah, so the UK has a different Food and Drug Administration than in the United States. For the case of Pexydartnip, it was approved in the United States, but because of its hepatotoxicity, it was not approved in the United Kingdom yet. So the drug options for Tgct in the UK are lower options. So you have the imatinib is still used, but generally surgery is still the main course of action if you're in the UK. For a giant cell tumor of the bone, they still use the dazunimab in the UK. So those treatments tend to be the same, and they are both approved in the United States as well as the United Kingdom. So yes, most of the drug trials are currently explored in the United States, and they have clinical sites in London, in these other places, but they're in clinical trials still. So the only approved drug is in the United States, or not in the UK is a better way to put it.
Okay, thank you. This next question is about diet. This person has had numerous recurrences in the soft tissue, so a knee replacement would not help. And the person's scared to try medication, but tired of surgeries. Could any change in the diet help? This person happens to have had GIST and giant cell tumor of the bone in 1989 with one recurrent. Are they related? Who would have thought?
Yeah, that's a lot of bad luck. So it's hard to say if diseases like that are related because giant cell tumor is so rare. So like you would see if you had GIST, you would see a larger proportion of GIST patients also having giant cell tumor, but that is not currently seen, possibly because of the rarity of the disease. It doesn't mean they're not interacting. It just means that currently we have no way to determine that and that it hasn't been shown. And then your other was food. I am a cell biologist, so I have to point out that I am, as a person, biased towards medicine. I work in medicine. I see the benefit every day of medicine. So I'm going to answer it in the most objective way, is that changing your diet can change systemic things like systemic inflammation, So your whole body, so like antioxidants, eating better, exercise, can all help general health. But can it treat a single disease is unlikely, which is why you go to doctors, which is why you take medicine. So it's worth trying. It's absolutely worth trying. It's minor changes in our life that actually can cause differences in overall well-being. And that is worth investigating. But as a scientist, I cannot say that that will cure your disease. It just hasn't been shown. But far be it from me to try it. As long as you let your doctors know if you're going on a supplement or any type of like turmeric or anything, talk to your doctors and consult with the appropriate dose.
And I think the Life Raft group will plan to host a future topic around this areas, a future webinar around this topic as well. So stay tuned for that. Since the genetic mutation is not considered inherited, are there any theories of what causes this mutation, such as radiation or even a virus? And there's actually another question where the person said, when I was young, I got electrocuted, or I hit my bone pretty bad. Could this have been the reason to cause the disease?
So I always like to say a lot of people have been struck by lightning per se. A lot of people have been in an injury or fallen and they don't result in this disease. So there must be something extra special about us. So while a lot of people, especially in TGCT, may report that they've had a prior injury, there's nothing that shows that that may be a cause. Depending on what you look at in the literature, you may see something that there is a higher predominance of injuries. Some papers say there's not a higher predominance. We call that a non-consensus. There's no consensus on it. And when there's no consensus, we don't dictate our behaviors or our actions or our scientific theories off of it. So currently there is no known cause. There's no dietary, there's no occupational, there's no stress that specifically may cause this disease in us rare, extra special patients.
What about proton beam radiotherapy?
Again, it's a big belief that if you throw enough darts at a dartboard, you're bound to strike something. It's so experimental, especially in this disease where it's, again, you have rare amounts of people. So like 300 people would be a very easy study to do in a very common cancer. But if you have this disease, having like 20 people would be amazing. So we were just talking about such small numbers that you don't get statistical significance to say it works. It does not work. For the experimental stuff, personally, this is a personal as a patient, I would wait towards last resorts to try experimental like proton beam therapy, the radioisotopes, but that's me. I'm more of a conservative approach person. If you have never had surgery or this is your first attempt at surgery, surgery alone may be enough. So it's hard to say whether that addition will help. So that's going to be based off of your specific case, how technical your doctor is. Are they used to using proton beam? Or in that case, it would be radiologist. But so it's more accessibility becomes more of the question than will it work at this point.
Okay. How can Pvns tumor cells destroy the bone? By chronic inflammation? Is it true that in some Pvns patients, bone never gets affected?
Yeah, in some patients, this is one of the giant cell tumors. While we say they're non-cancerous, they are unpredictable. They do whatever they want, and they do whatever they want in certain people. So in some people, the giant cell tumor grows to a certain extent. It causes low amounts of stress, so there's no swelling, there's no signs, and then they stop growing. And that person can monitor and never need surgery. That's why it's in some patients, it destroys bone, usually through inflammation. So it keeps growing, it grows depending on the joint in small spaces that aren't meant to have tumors grow. And that causes stress on the bone, that'll cause decay of the bone. And in some cases, it can cause things like necrosis. So it really depends. That's why patient-centered care is very important in this disease and finding a doctor you trust and that you believe. Because it's a huge issue is that there's no standardization and there's no standard way these behave. So in patients where you're at the end of the road, where you've had 6 recurrences, it's much more clear cut to try anything. But when you're around 1 surgery or 2 surgeries, you're not quite sure what to do because you could be a patient where you have 1 surgery and it never comes back. So it's patient-centered.
Yes. Okay, great. This person has diffuse Pvns in the ankle, had 9 surgeries so far, most of the time open surgeries. They've been part of a trial together with Roche Laboratories, which involved the same treatment as for a breast cancer without few components. They would like to know, what are the amputation criteria? Are they based only on the pain or on the number of damages caused by the tumor?
So it depends where you live. In the United States, generally, because we are more a market, you can go to different doctors. You have more options on who is willing to do an amputation. Some doctors have a belief that if it's not cancerous, there's really no need to amputate. So it really depends. There's no set criteria, which is one thing that needs to happen in this disease, is standardization and monitoring, diagnosing, and treating. So for people who've had multiple surgeries like you, having 9 surgeries is a lot. Amputation tends to be based off of function. So can you still, have you had a fusion? How useful is that limb still? And then surrounding damage generally. In some places you can have it removed just because of pain, because of 9 surgeries being a huge issue and very hard to sustain quality of life. And that may be, it depends where you live, that may be acceptable as well. So it depends your surgery center, it depends your doctors on whether they're comfortable removing a limb. You also should consider that there are a lot of symptoms that go along with just limb removal. So while that's the last case scenario, and it's definitely a case for many patients who just can't deal with this disease anymore, you would have to find a doctor who's, if you have the damage, it's a little easier to convince them, but who's willing to go on the journey with you of phantom limb issues and hopefully getting a prosthetic in that experience.
Another person said, is there like a number, like, of how many surgeries is just too much? And are there deaths related to this high rate of being on anesthesia?
So there is no number. My hope from this whole experience is the people who have power to change our experience as patients from the other side, like pharmaceutical companies, hospitals, doctors, see how little standardization there is. So there's no standardization on what's considered too many surgeries. Usually they cut off inoperable somewhere around 3 to 9. That's a huge range. So it also depends your location and the damage done from each surgery. The belief system of doctors is do no harm, which is a great standard. Because of that do no harm standard, if the surgeries would promote more damage than they would help, they stop doing surgery. So that's why that's where I said age may play a role. Younger individuals who are more active may be more likely to recover, may be more likely to be able to sustain multiple surgeries than someone who's a little bit older, has a slower immune system, slower healing. So it depends on other factors outside of that. I wish I could give you a number on how many is too many. I've had 6 surgeries and it still doesn't feel like it's ever going to end. So it really depends the patient and how much they're willing to go through.
All right, I'm going to ask one more question before we sum up. So can a localized form of Pvns develop into diffuse?
Yeah, so you can have one localized tumor and you can have one diffuse tumor. I know that's not convenient whatsoever. Generally, you go with the diffuse diagnosis. If you've ever been given it, you usually go with that. You can have diffuse, which with small nodules or localized nodules as well. Generally, you fall into one of the categories, but because of the unpredictability of these diseases, they do mesh. So you can have both.
Okay. We didn't answer everybody's questions today, but the Zoom platform allows us to go back and we can respond to you privately to answer those questions. There were some questions involving, like, is there a website, the LifeRaf Group website? I will say the LifeRaf Group website is liferafgroup.org, but we don't have giant cell information on there. We do plan to create a new site to store this information. We plan to create fact sheets and education materials and do a lot more. I encourage anybody who's interested in certain topics to type that into the post survey after this event. But also if you're interested in volunteering, because I see that there are some people who are interested in volunteering, you might have a certain skill set that would be really great for us. I mean, whatever we can do to help empower the community to learn more about the disease and get the information out there. Because I think I know a lot of you didn't know much at the beginning and still say that there's not a lot out there. So, you know, the LifeRaf group wants to help assist on making sure we have as much information out there so that patients can find it easily. And also just because we have very strong relationships with the doctors that work in this disease, we do plan to have a lot more discussions with them to see how we can better service the community. So, and you know, Sydney's going to be a really large part of that, but if there's anybody else who's interested, please let us know. So please share your information in the survey. And we're really excited that you were able to join us today. And thank you very much to Sydney for an excellent presentation and to be thrown all those different questions that she wasn't prepared for, but she did a great job with. And I wish everybody a lovely day and weekend. Take care.